I am delighted to be presenting the diagnosis, management, and challenges of antiretroviral therapy failure among children and adolescents in a resource-limited setting. We know that worldwide, there are about 101.8 million adolescents aged 10 to 19 years living with HIV. 85% of them are in sub-Saharan Africa, and 60% of them are girls. In Uganda, where I come from, 1.4 million people are living with HIV and AIDS, and 130,000 are adolescents aged 10 to 19. The majority are perinatally infected. And the current prevalence of HIV among adolescents is 2.8%. According to the Uganda AIDS Control Program, the highest prevalence of HIV is in the urban areas, including the city of Kampala. So Baylor, Uganda is a center of excellence. It was started in 1988, and antiretroviral therapy was initiated in 2003. The HIV clinic was started around the same time and has registered over 12,000 adolescents and young people by January this year. There are two groups of HIV positive adolescents who are vertically transmitted and those who are behaviorally transmitted. And as these adolescents mature and have their life expectancy increase, they face various challenges, including building a social and sexual identity, making education and career choices, gaining autonomy from their parents, and also promoting personal adherence to their treatment. The availability of antiretroviral therapy has resulted in increasing numbers of adolescents living with HIV and AIDS. And yet, these come with various challenges of coping with the stress of being HIV positive. There's been a great evolvement of antiretroviral therapy. We know that in Uganda and also in the PIDC, this was introduced in around 2003, 2004. Initially with meager resources, and then currently we have the test and treat approach that looks at initiating both children and adolescents on antiretroviral therapy. Before, adolescents and children took lots of drugs, lots of pills, syrups and tablets, but now we have had optimization of treatment to the extent that a child or an adolescent takes a single pill or very few medications. According to the recent data from Baylor, Uganda, the distribution of antiretroviral therapy among children and adolescents includes the majority on first-line treatment, that's about 75%, and then 24% are on second-line treatment, and 34%, about 1%, sorry, are on third-line treatment. So the majority are on first-line treatment, a few are on second-line, and a little number is on third-line treatment. For the children and adolescents below the age of 19 years, there's viral load testing done on a 6-monthly basis. But as you can see, the adherence to antiretroviral therapy and subsequently the viral load tests are really low for children between 1 to 4 years, 84% for 5 to 9 years, 86% for 10 to 14 years, and 85% for those between 15 and 19 years, which generally shows that children and adolescents are not achieving 100% viral load or adherence to antiretroviral therapy. The regimens that adolescents are receiving, first line are 71%, second line are 28%, and still the third line around 1%. Not so different for those below 10 years and those above. For the adolescents and children on antiretroviral therapy, the male-female ratio is almost the same. And if you look at a 12-month viral load cascade, the adherence increases to about 99%. There are various challenges for adolescents living with HIV and AIDS, which also affect their adherence to antiretroviral therapy, including early sexual activity, continued engagement in sexual relations, and also lack of disclosure. So in terms of optimizing care, to promote youth-friendly services, it's important to train the healthcare providers, promote confidentiality and provide consent, but also seriously cater for the socioeconomic issues and empower the youth to live with HIV, because this will improve adherence. In case you forget whatever I have said, when you're treating adolescents living with HIV and AIDS, and this also applies to children, it's important to have a competency donut that includes knowledge and skills improvement, respecting these adolescents and children, having a non-judgmental attitude, respecting individuals for their dignity, and also understanding them as change agents. So in terms of treatment issues, we already mentioned adherence is a challenge, disclosure is a challenge, but also the ongoing risk of transmission is a challenge, and also transition to adult care. We all know now that undetectable equals untransmissible, and it's important to ensure that all adolescents and young people are undetectable so that they do not transmit HIV. There are various challenges of transitioning to care, including financial independence, support to adherence, and others. And it's important for us to appreciate that transitioning to adult care is not necessarily images, but it's important for these adolescents to be comfortable in the presence of adult patients. And when we promote transitioning, it improves the self-concept and sense of competence. It also promotes independent living. Transitioning in HIV is part and parcel of improving adherence. And as adolescents living with HIV grow into adulthood, it's going to be necessary for us to be able to transition them. This is just an example of how we promote transitioning at the Baylor, Uganda clinic. We have a psychosocial support club, young people transitioning to other different psychosocial clubs. We've done various studies on disclosure challenges, and these affect adherence. We know that disclosure is more difficult for girls because it's associated with stigma. And also the SARS-CoV-2, the COVID-19 pandemic, has created its own challenges. And since the beginning of the pandemic, we are seeing less and less of our patients physically, and this is affecting their adherence. Uganda has had its own brunt of the COVID-19 pandemic, and everyone is affected, but those especially living in poor communities are most affected. So there are key issues related to the lockdowns, repeated lockdowns, multiple waves, electronic review of clients, and reduced face-to-face client contact because of infection control and prevention. Obviously, there's various challenges of school returns and also scheduling of patients. And I just want to quickly take us through a case of MN, a 25-year-old individual who was initiated on antiretroviral therapy in 2004. Both her parents are deceased. She was living alone, but was working. And I'll just quickly show you that she started on D40, then transitioned to AZT. In 2009, she was put on TDF3-TC efavirenz, but her viral load trends were concerning. In October of 2020, her viral load was 1,700, and she had repeated adherence counseling sessions. She was switched to a dolutegravir-containing regimen, and after 3 months, she was undetectable. So our plan is to support her with adherence. This case demonstrates that even though a patient continues to fail, they should continuously be supported and optimized to the best treatment. Case 2 is a 7-month-old baby who I saw about 2 weeks ago. She presented to us as a new diagnosis of HIV. She had pulmonary tuberculosis, severe acute malnutrition, and pediatric HIV. She'd been started on abacavir, 3-TC, lopinavir, and ritonavir. Her mom is in a polygamous relationship and was not able to adhere to her therapy because the mom needed to put her treatment in a fridge, and she also said the medication was bitter. Fortunately, we've now had DTG 10 milligrams, squad tablets, and even the pellets. And now baby has been switched to dolutegravir. And this has improved her adherence to treatment. And the follow-up of the TB and malnutrition units is much better. These are our national guidelines, including the 2nd and 3rd line treatment guidelines. And the switch is dependent on the initial treatment that the patient had. In terms of the 3rd line ART flow, the first stage includes lab testing, a clinical decision by a team of experts, then 3rd line implementation. I know I did mention that we have a very small percentage of our patients on 3rd line treatment, but moving forward, we are going to get an increasing number of children and adolescents switching to 3rd line therapy. So the time is now, and the time is ripe for us to optimize therapy for our patients, because we know that adolescents and children are going to be the population that's going to be longest on antiretroviral therapy. So it's important for us to have targeted interventions, including optimizing their antiretroviral therapy right from the 1st line treatment to their 2nd line treatment, and providing antiretroviral therapy even during this COVID-19 pandemic. I want to acknowledge my parent department, but also to sincerely acknowledge the Baylor Uganda team, IDI, as well as adolescents and caregivers, and the organizers of the interest meeting of 2021. I'd like to sincerely welcome all of you to the interest meeting in 2022, which is going to be held here in Kampala, Uganda. Thank you very much.